of the issues that we need to factor in is that, is this as good as, better than, or same as seeing a patient in the clinic, just from the, from the doc experience? I know that from the interpersonal and the ability of what you get, obviously you can't examine a patient, but does it make it kind of a hardship to set up with the lighting, the sound, the positioning, everything like that, compared to just walking in a room, something that we have been doing, and we are used to interacting with other people since we were babies, and we have had very little experience doing this through a screen interface. And most of us are getting a lot more of that experience now in the last several weeks than we had in the preceding years. But I think both for patients and for docs, I just wonder whether this is something that people will find aversive and an annoying process, or something that people will find overall convenient enough that it should be the default way to go, unless there's a clear reason you need to be touched or be in the same room. So Ben, if I can start with you just on your thoughts of, whether you think this is an experience that, has appeal to docs and to patients beyond necessity.
Yeah, I think on the surface, there's probably very little difference between a visit that goes down via telemedicine versus a visit that goes down face-to-face, minus the exam. And we can talk or joke about how exams have fallen out of favor. All of the novel techniques we have in terms of imaging and blood work that may better assess tumor biology or how the patient is doing. But I think on the surface, that's all you're really missing. I think the issue is more the intangibles of what happens when you meet a patient for the first time, and it really kind of highlights that sacred relationship between doctor and patient as an oncologist, and the trust that is built over time with that face-to-face interaction, and some of the ability to read body language. And we're talking about shared decision-making, and we're talking about goals of care, and we're talking about toxicities, not only just side effects from chemo, but financial toxicities from chemo. So there's so many elements, and this relationship is so complex and has so many different facets to it, that I think those facets are better tackled, I'll be honest, face-to-face. I think you're going to get more pushback in the end with this from patients than you are doctors, because I think patients truly value that face-to-face interaction, even if it means traveling through traffic, even if it means that they need to be with another person, needs to get them there, a loved one needs to take themselves out of a job to get them there. I think that the pushback will be more from patients, but I will tell you that it really, for me, is the intangibles that of the things that you really can't measure that are a really good relationship between an oncologist specifically and a patient, that may not be able to be fostered via telemedicine as it can be in person.
How about you, Jared? What are your thoughts here?
My most important thought was well expressed by Dr. Levy. I very much agree that for the most part, this is just clearly inferior for that human relationship. However, I do see silver linings. Some of them we've talked about already, the practical ones. But there are others. We joked about my kids in the background. But the two times that they've come into the frame with patients, it's actually, I think, been quite therapeutic. With patients, they're often seeking a way to get to know the doc a little bit better, right? They ask to see pictures of my kids. They show me pictures of their grandchildren. We talk about food and wine and local restaurants and whatever it is we can find that we have in common. And, being an uptight New Yorker in North Carolina, sometimes tease each other about what's not in common. But, all of that shares looking for that bond and seeing them in their home, them seeing me in my home, having my kids come into the frame briefly. I was actually quite nervous about that. And, it's limited experience thus far, but that can actually be a silver lining. Ben touched on the importance of exam and joked about when it is and isn't useful. I'll say out loud what we're not supposed to. It's probably 1 in 10 times that I see a patient that the exam is truly productive for me. Those times are real, and 1 in 10 to me is still a lot. That's not a trivial number. But, you know, feeling that edema in a patient's ankles that alerts me that they might have a DVT, seeing that thrush in their mouth that tells me that I should give them an anti-fungal. Neurologically, the informal neuroexam, just hearing someone speak and seeing them get up on the exam table can be very productive. Feeling that subcutaneous nodule. In my head and neck practice, feeling a patient's neck and looking in their mouth. These things matter, but again, we're not in an era at the moment where we're saying we're going to see no patients in the office, right? No one's gotten to that. We're at a point of saying now and in the future, are there patients who can be appropriately seen in their home, or perhaps in looking at their total situation, both cancer, social, personal, be better seen in the home? And the answer is clearly yes. I did want to touch on one other facet that's more clinician directed, but it's becoming much harder to compartmentalize the components of my life. I think of my life as my patient care, my research, and my personal life. And these have been much harder to keep discrete than before. Normally, I see patients a day and a half a week, and now I am a 5-day-a-week clinician. Because if you can just hop on a video call or a telephone call, there's no reason on a non-patient care I can't do that. Normally I don't see my children 9 to 5, but now I do, and they can get in the way of a research meeting or a clinical care. And that's the reality of at least the COVID-19 era of virtual care that does produce a certain challenge for the clinician.
I think that's a really good point. I mean, we've been doing this for years, the ability to, you know, work on your laptop at home, to get email, to send stuff. I mean, you can do your work at home, and that's a blessing and a curse. And now even more, you can do clinic at home, and it all bleeds together. And I think that has good and bad aspects. You know, one final thing that I think we just need to think about is the concept of webside manner, which I think obviously a lot of our interactions with patients are things that we've been doing for years to decades and trained in. But there is a different element now that it is through a screen, and we have to deal with hardware and computer lag and the web camera and the lighting and sound and also how you interact, that some practical things that we didn't have to really think of before, but now you need to make sure that the web camera isn't pointed up our nose, or that the lighting isn't so bad that you can't see each other. And this is also foisting that on the patients too. I mean, a lot of them, for us, I think it's going to lead us to need to develop dedicated spaces. This is not something that we're all working in academic centers, and so we're largely working in shared clinics with a workroom that may have 8 computers and multiple docs simultaneously, all in a pool of exam rooms. I previously worked in a place where my exam room had 3 rooms that are very close to my office, and you could kind of partition and go from live clinic patient to televisit. I can't do that. You know, if you're working in a shared clinic space, that's not ideal. And so I think we're going to need, as docs, to become adept at this, but it's a totally different skill set. We're going to need to figure out how to make it work for us. But it's not something we were born doing or had almost none of us trained in, during medical school in telemedicine, interchanges and how to do that effectively with patients. And patients haven't had this either. So I think this is something that, as we acknowledge there's challenges and imperfect aspects to telemedicine, we have to at least hope that we're going to get better at it, because we just dropped out of a helicopter into this situation, and we have had no training and no experience in this on either side. But hopefully we'll get better. But it is a different skill set. I'm just interested, Jared, maybe if you could start in any thoughts to add to that?
Not really. You said it well already. It's totally new to us. It's totally new to our patients. I think that we've learned and built up certain skills for understanding the common the right word here, elements perhaps that our patients bring to the encounter, the things that they're going to be anxious about, the barriers to their care, the things that are going to be on their mind in particular situations. I think we're all going to have to learn to be patient with patients who are not used to this, right? Because we're going to get practice in this. They are not to the same extent.
Right.
And we're going to have to support our colleagues. The three of us nearly by definition are more comfortable with this sort of work because here we are doing a webinar for Grace, right? We've done this sort of thing before. Some of our colleagues have never been recorded in this way. Some of our colleagues have never sat in front of a green screen. So there's a period of adaptation, and we're going to have to show the same compassion and patience to our patients that we've learned to do for other things.
Ben, final word on this?
Yeah, I'm reminded of the few initial consults I saw this past week via telemedicine, and just a, reminder, we may easily be able to assess vulnerability or anxiety when we walk into a room, and we need to have that same sort of approach even over telemedicine, that we can't let the medium disrupt compassion, we can't let the medium disrupt communication. I try to make a point at every first this week with the telemedicine visits that were initial consultations, just to, wave, hi, how are you doing? And try to deliver that same compassion, because I think some of that can get lost. And we need to remember patients are as anxious, if not more, or as scared. These are cancer patients that are going through challenging times. And even though we have a different medium, we need to be mindful to be ourselves and try to assess the best way we can that vulnerability and anxiety, even in a virtual space.
I think you bring up a great point. One tip I've gotten is to kind of break it up and maybe wave in and wave out.
Yep.
And just acknowledge this is different. Here we are. And that's, the elephant in the room in the virtual space, but to say, hey, this is new for us, and dispel all of that right away. So whatever issues we have, I think we can really say that telemedicine is a helpful tool for some patients right now, particularly in this period of social distancing and needing to be judicious about those clinic exposures. And we will need to see how sustained this is, but it has at least helped us reflect on how ritualized some of these visits should be and what we should offload to a different medium, at least intermittently. So thank you guys so much for taking the time.